Schatten der Pandemie. Insbesondere freue ich mich, dass wir zwei Gesprächsteilnehmerinnen heute begrüßen können, die uns die Perspektive des globalen Südens näher bringen, der von den Folgen der Pandemie aktuell, aber auch in Zukunft sehr besonders betroffen sein wird. Und dass wir eben nicht nur die Debatte führen über die Folgen im globalen Süden, sondern dass wir heute die Möglichkeit haben, dort Informationen aus erster Hand zu bekommen und auch entsprechend zu diskutieren. Deswegen freue ich mich, dass gleich oder auch jetzt schon zu uns zugeschaltet sind Dr. Priya John, Generalsekretärin der Christian Medical Association of India, und Dr. Joseph Ngozi Chukwu, medizinischer Berater der Deutschen Lepra- und Tuberkulosehilfe DAHW in Nigeria. Ich freue mich sehr, dass Sie bei uns sind und dass Sie uns Ihre wichtigen Einblicke geben können. Noch vielleicht kurz zwei Sätze zu mir. Mein Name ist Tina Rudolph. Ich bin Mitglied der SPD-Bundestagsfraktion, bin Mitglied im Gesundheitsausschuss und seit gestern Sprecherin für globale Gesundheit und AG-Leiterin im Unterausschuss globale Gesundheit, der sich in dieser Legislaturperiode etwas spät, erst vor 3 Wochen konstituiert hat. Aber wir werden in den nächsten Wochen in viele Arbeitsschritte starten und die Themen, über die wir heute sprechen, werden da auch sehr hoch angesiedelt sein. Es ist ja so, dass wir heute vielleicht einen der wenigen Vorteile der Pandemie, den sie uns gebracht hat, auch hier genießen können, indem wir zwei hervorragende ExpertInnen zugeschaltet haben und uns miteinander austauschen können, obwohl wir an verschiedenen Orten sitzen. Aber das ist auch tatsächlich einer der wenigen Vorteile, die ich aus den letzten 2 Jahren ziehen würde. Und sowohl hier in Deutschland als auch international und in der globalen Perspektive werden wir Jahre, wenn nicht Jahrzehnte zu tun haben, das, was die Pandemie auch im Hintergrund hinterlassen hat, aufzuholen. Und man muss es so deutlich sagen, es ist anzuerkennen, dass in der Bekämpfung vieler Krankheiten, die ansonsten Menschen beschäftigen, auch in anderen Regionen der Welt, dass die eindrücklicher werden, dass teilweise die Bekämpfung von Krankheiten stark zurückgeworfen wurde und dass das sicherlich für uns eine Aufgabe auch in den Jahrzehnten sein wird, bei der auch Deutschland einen gewichtigen Teil leisten wird und auch leisten möchte. Auch das möchte ich an dieser Stelle schon bekräftigen. Ich möchte aber ansonsten gar nicht so viel Zeit veranschlagen, denn die müssen und wollen wir heute natürlich, so gut es geht, mit unseren ExpertInnen nutzen. Und deswegen darf ich für die Moderation übergeben an Melissa Scharwey von Ärzte ohne Grenzen. Vielen Dank.
Ja, vielen Dank, Frau Tina Rudolph, für Ihr Vorwort. Mein Name ist Melissa Scharwey. Ich arbeite als politische Referentin bei Ärzte ohne Grenzen und ich freue mich, dass ich das Fachgespräch heute Morgen vom Memento-Bündnis moderieren darf. Bevor ich jetzt gleich ins Englische wechsle und unsere beiden PanelistInnen willkommen heiße, habe ich noch 3 kurze praktische Hinweise für Sie. Einmal noch einmal eine Erinnerung, dass die Veranstaltung aufgezeichnet wird. Dann, dass wenn Sie gerne von Englisch auf Deutsch übersetzt haben möchten oder andersherum, gibt es den Übersetzungsbutton, den Sie finden mit so einem runden Globus. Da können Sie dann draufklicken und es wird simultan für Sie übersetzt. Und Fragen, die vielleicht schon während der beiden Präsentationen, die wir jetzt gleich hören, aufkommen, können Sie gerne sammeln und dann für die Diskussion in den Chat stellen. And with that, I'm switching to English now to welcome our panelists and facilitate the discussion. And before that, also to make sure everyone has heard this, 2 very quick practical reminders. One, that this event is going to be recorded, and the other one, that if you would like to use translation, you will find a translation button in the bar of options to have translated from German to English or from English to German. And with that, I would like to very warmly welcome Dr. Priya John, joining us from India this morning, and Dr. Joseph Chukwu, joining us from Nigeria, who will both give us first a brief input, and then we will have around half an hour to ask them questions and discuss. Starting with Dr. Priya John, I already can see you, great. She is a medical doctor and currently General Secretary and CEO of the Christian Medical Association of India. It is a 117-year-old membership organization of Christian healthcare individuals and healthcare institutions in India. And Dr. Priya John has worked in various capacities, managing a small rural hospital, teaching in private medical college, working in a hospice, providing palliative care, and also doing research work. And in her current position, Dr. Priya works with the government and development partners such as UNDP, UNICEF, DAHW, the WHO, and many other also national level platforms for health and related activities. And Dr. Joseph Chukwu, who will give his input after Dr. Priya, is also a medical doctor and is working for the German Leprosy and Tuberculosis Relief Association, GLRA, or DAHW, in Nigeria, where he's serving for over 25 years as a medical coordinator. And him and his team provide wide-ranging support to the national response in neglected tropical diseases in Nigeria. And before joining the GLRA, he was a tuberculosis and leprosy program manager for Imo and Abia states in Nigeria, and also earlier served as a medical superintendent. And he is also a peer-reviewed author and co-editor of a book which gives first-hand accounts of experiences of people affected by leprosy in the defunct eastern region of Nigeria. Dr. Priya and Dr. Joseph, we are very excited to have you here today, and I look forward to learning from both of you. And without further ado, Priya, please go ahead with your input.
Thank you very much, Melissa. Respected members of the German Parliament, key decision makers, my fellow non-governmental organizations, scientists, and every participant present here. From India, it's in the morning, and I'm sure it's there too. I'm really humbled, and as the Christian Medical Association of India, it is truly our privilege to be a part of this discussion where we will give a few insights, and I like the word input, into what has been going on in our country in the health challenges in the shadow of the pandemic. As you know, India is a very complex country, but we are proud to be a part of such a diverse culture with so many challenges. Let me just quickly break it down from the world view and funnel it down to what actually happened at the local level with respect to us as the Christian Medical Association of India. Yes, on a global level, there is the Global Economic Governance Platform, which is the G20. And yes, India will take on its presidency this December 1st, 2022. And we look forward to hosting the G20 summit next year. Now, why is this important in this context? It's because from the G20 summit, it trickles down into one of the main focus areas, which is the Sustainable Development Goals of 2015 to 2020. And from there, the one Sustainable Development Goal, which is important for us as healthcare workers, is the SDG 3, which is equitable health, outcome and well-being, global public health security, and resilient societies. All these words could not have been more true, could not have been more proven correct during these last 2 years under the shadow of the pandemic. Now, from the SDG 3, where we come in as the Christian Healthcare Medical Association of our country, where the importance and relevance comes in is for universal health coverage. Now, what is this universal health coverage in our context? Now, when Melissa told me to give my input, please, I would like to state humbly that my input comes from my 275 Christian medical mission hospitals located in about 28 of our Indian states and union territories. They come from inputs we have had over 40 different meetings, 13 regional conferences, 5 national conferences, and inputs have come from the leadership level, the second line leadership, students in the healthcare, and so many other national development partners where we have got different perspectives of the challenges that have come out during the pandemic. Now, what are these challenges that have come out? Now, from the health system strengthening, which is one of the main areas contributing to the universal health coverage, the action which had to take place was equity, quality, responsiveness, efficiency, and resilience. Very strong words. And in each of these, our institutions spread across our country have demonstrated different perspectives related to this. What were they doing for equity? During the pandemic, during the lockdown, all the doors of our mission hospitals were open. Many of the private sector closed down. And to be stable, you have to have your organization stable first. So they ensured that their staff were reassured, and then they motivated them to take on the pandemic because nobody knew what was going to happen. There was no preference given to any of the communities that were struggling. Everybody was welcome, and they understood what is the need of the community. And they had innovative ways of dealing with providing for that need. The second, with regard to quality for HSS, what did our institutions do? They maintained a fantastic database for all their important diseases. For example, leprosy, tuberculosis, and the diseases which needed chronic care and where they had to have their medication. They were on the phone with their patients. So maintaining a database of all patients was important, and that was done many times manually because many of our hospitals do not have fancy hospital information systems, but they maintained it and manually called a lot of the patients. So they did not neglect the treatment that was due for important diseases like tuberculosis and leprosy. They had committed staff willing to work, 2 shifts. That was giving quality care. Responsiveness. Immediate needs were taken care of because first the staff were stabilized, they were motivated, they were reassured of safety, and then they started looking at short-term goals. Okay, first wave, what do we do? Ensure that all the staff have adequate PPE. All the staff understand what the disease is. So a lot of webinars, a lot of training right from the security guard right up to the CEO. They were all told about this novel coronavirus. Then for the long-term goals, they started, especially when the second wave hit, there was a lot of oxygen processes and systems set up, a lot of engineering done, plants set up, oxygen concentrators procured. All the long-term planning was quickly put into place. But yes, the second wave really took a toll on our health systems, and the weaknesses were brought out very clearly. And what were those weaknesses? It was mainly there was a huge hit to the demand supply because of the lockdown, because of transportation issues, the escalating costs, availability of drugs was a big issue. But in every area, when we interacted with the hospital administrators, they all talked about how they put management principles into effect and stocked up for 3 months, stocked up for 4 months, especially the key drugs. And who was telling them what the key drugs was? One is our government, the Ministry of Health and Family Welfare stepped up to give excellent guidelines and protocols. And in the second wave, the Christian Medical College in Vellore stepped up with fantastic protocols to address level 1, level 2, and level 3 of COVID, as well as its complications. So that was a huge plus point for us as the Christian healthcare institutions. The vaccine. the government took part in, they really stepped up in the first wave and then in the second wave to ensure first all healthcare workers were given free vaccines. There was no problem, including medical students, nursing students, allied health students, all got the vaccine and free of cost with no problem. In the second wave, of course, there was a different strategy where there was a little bit of payment that was required to access the vaccine for others, not for the healthcare workers. The last one is about, of course, efficiency was in systems, protocols, and treatment, and of course the vaccine, to ensure that everybody was protected and there was no issues related to the affecting or getting infected by the coronavirus. Resilience. Now this is where there was a new activity that came up for our mission hospitals. They started stepping outside their boundaries. They started networking with other hospitals, the Catholic health sector, the other secular sector, their own mission network hospitals who they never really worked with before. They started working with the government. Now, government system in India is so complex because we're so big. So the district collectors became very important, stakeholders for our institutions to do well and to serve the community better. So they stepped up. They stepped up with the government. They created networks, and the church, because all our 275 institutions are church-owned. So the Protestant church and the Orthodox church stepped up in a fantastic way to ensure that somewhere the communities were benefited as well as the mission hospitals were stable. And of course, the whole Catholic health network, along with the Protestant and the Orthodox, we submitted a letter to the Prime Minister of India saying, we are here to support. And use us in any and every way you want to ensure that our country has all the needs required to serve the community during this very challenging time, whether it is in the area of neglected tropical diseases, ongoing vaccination programs, maternal and child health care, or just stepping up as a COVID center. We are here to do all of these. And the government recognized that, and they would interact with us to ensure how many beds do you have, what is your ability, can you become a maternal child health, can it become a COVID center overnight? All those interactions happened, and I must say many of our hospitals did step up, and over 90% were engaged in COVID care. The last point is about the whole idea of what the pandemic brought in with its volatility, its uncertainty, its complexity, and ambiguity. The VUCA principles, it came to light during the pandemic in every area of healthcare, whether it was health education, whether it was health, services delivery, demand, supply, and all those things really, all these areas it affected. And what was the answer to that? Vision. Vision of every organization from a broader perspective, it came down a little bit. There was, even though the vision might have changed a little bit because of the challenges that came up, the mission did not change. And the mission is to serve those communities who were marginalized, who are poor, and who had no access to health or to the vaccines or whatever drugs, or so many areas. Those were the communities we did not compromise in any way. We had a better understanding of issues. When a health system crumbles, the understanding was there, which was shared across all learning platforms, and CMA took a big role in making sure those learnings were shared. Clarity of purpose in all areas, who do we say yes to, who do we say no to, all that was clear, especially when the donors came up. Who are the donors we will say yes to, who will say no, we cannot do this now, we are focused on doing this for our community. And of course, the last and most important, being agile. And that is what the whole pandemic taught us in various areas across, the health system delivery, health education, insurance, all these areas, it taught our mission hospitals to be agile. And there are numerous examples which we are so proud of, and we have recorded and hope to share, in a bigger audience also across for our own learning. So this is some of the learnings we had as the Christian Medical Association of India. And I really want to say thank you for this time, and I'll be happy to answer any questions during the discussion time. Thank you.
Thank you very, very much, Priya, for your input and for this national overview you gave us. It sounds like very impressive work during really, really challenging times. And I already have plenty of questions I would like to ask you later. But first, I would like to welcome our second panelist, Dr. Joseph. Whenever you're ready, please switch on your microphone and your video, and you can go ahead with your input.
Yeah, thank you very much, Corina. I hope I got it right. Madam Chairperson, honorable members of the German Bundestag, distinguished members of the Memento coalition and other NGOs here present, my distinguished colleague, Priya, ladies and gentlemen, I thank you for the honor and privilege to address you today. It is my fervent hope that the perspectives we share would help provide you a clearer picture of the lived experiences of people affected by these diseases in the global south. I took the liberty to slightly rephrase the topic. Thus, what were the hidden costs of the containment strategy employed in trying to halt the COVID-19 pandemic, especially with regard to the health sector in the global south? I hope you bear with me. I suppose that is my way of answering yeah to the question, whether or not was. Before COVID-19 vaccines came on stream, the global public health response relied largely on a slew of non-pharmaceutical interventions, including social distancing and lockdowns. While helpful, these had significant negative effects on case detection and management of neglected tropical diseases in Nigeria. Unlike the preventive chemotherapy NTDs, the main strategy for control of case management NTDs like leprosy, otherwise known as Hansen's disease, and Buruli ulcer is case finding and treatment. Madam Chairperson, it is important to clearly state at the outset that most of the fault lines or problems we're about to associate with NTDs in the COVID-19 pandemic era actually predate the outbreak. Widespread poverty, widening inequality, lack of good governance, endemic corruption, fragile health systems in the global south, and pervasive social injustice. These forces ensure that NTDs, neglected tropical diseases, or diseases of neglected communities, as some critical observers prefer to call them, survive and thrive in the 21st century. What the pandemic did was simply to lay bare and magnify them. To succeed, therefore, any attempted solution must be bold, multifaceted, and just. Were there other health issues that impacted the population while public health authorities focused on COVID-19 containment? The answer is clearly yes. Nigeria experienced outbreaks of cholera and Lassa fever across several states, resulting in scores of fatalities, many of them children and young adults. There was some anecdotal evidence that hunger and starvation were perceived as greater challenges by the poor and unemployed than any risk posed by COVID-19. Although hundreds of millions of naira were expended by government on the purchase of foodstuffs for distribution to the populace as palliative, to cushion some of the effects of the pandemic, there were widespread rumors and indeed protests over alleged corrupt practices in the process. I should note that Nigeria budgets a meager 3 to 4% of GDP for the health of its over 200 million population, far lower than recommended by the WHO or indeed the African Union. Madam Chairperson, let's now look at some details of the effects of the pandemic response on the NTD control cascade. Case finding. Before the pandemic, our organization supported frontline health workers to organize and conduct active case search in communities and schools. This entailed convening and screening scores of community members at agreed locations. Social distancing and occasional lockdowns put paid to these activities, thereby significantly reducing the number of cases detected, treated, or notified. Compared to 2019, case notification for the 15 southern states supported by GLRA dropped by 25% and 30% in 2020 for BU and leprosy, respectively. One should note that passive case finding also suffered. This is because self-reporting patients were reluctant to approach health facilities for fear of contracting COVID-19 at the health facilities. Similarly, many health workers were hesitant to attend to patients without proper gear, proper PPE, personal protective equipment. Screening contacts for signs of disease and providing preventive chemotherapy to eligible contacts, which was routine practice in the program, also had to be shelved in observance of social distancing during the pandemic. It was also the case that said program managers and some of their senior staff were repurposed to serve as COVID-19 incident team members. The expected long-term implication of delayed diagnosis include increased occurrence of visible deformities and continued transmission of infection in the community. For Bruley ulcer, BU, delayed diagnosis meant that ulcers progressed, resulting in some cases to contractures at joints and other complications. For some school-age children, this led to school dropouts with all the attendant social stigma and compromised features. Treatment for leprosy and BU was interrupted, partly due to internal restrictions of movement, as well as due to international supply chain disruptions owing to the pandemic. At one point in the Nigerian program, hundreds of leprosy patients were reportedly unable to continue treatment due to resupply problems. Potentially, this could lead to increased risk of drug resistance. Management of leprosy reactions. Patients with serious episodes of leprosy reactions, who were usually managed at referral centers, were unable or at times unwilling to access the referral centers owing to either social distancing, lockdowns, or more often due to fear of contracting COVID at the health facility. Attempts were made when the patients or relatives phoned the referral hospitals or GLRA office to provide advice remotely by telephone. Management of medicines and other commodities. This activity was also dramatically curtailed during the pandemic for the same reasons cited above. This means that many patients were left to fend for themselves in terms of procurement of medicines and dressing materials, a double jeopardy, as some of these patients were already dependent on arms to make ends meet. NTDs and COVID-19 vaccination. In a recent survey by GLRA, quite a number of persons affected by leprosy complained that they were deliberately sidelined by those administering COVID-19 vaccines because the health workers did not want to touch them. What a shame. The inimitable late Professor Paul Farmer would have called out these health workers for letting fear trump their sacred duty of care to all in need. We would argue that precisely these, the most vulnerable among us, should be prioritized. Mental health. Persons affected by NTDs, for instance, leprosy, urinary ulcer, and lymphatic filariasis, are known to suffer from high prevalence of depression due to the nexus between disability, stigma, discrimination, and depression. Some of this is mitigated by participation in self-help groups, as well as counseling by non-mental health experts. All these were upended by the pandemic, thereby exacerbating the mental health problems of these persons. Supervision and monitoring, as well as training activities, had to be drastically curtailed in deference to COVID-19 containment measures. A negative impact on quality of care is expected down the line. This is especially so in the current situation where many frontline health workers lack leprosy expertise, leading to inability to confidently diagnose leprosy or its complications. I would like to join Corina here to mention a few unintended positive fallouts of the COVID-19 pandemic. So thankfully, the pandemic was not all doom and gloom. It compelled the increased use of and proficiency in remote working on Zoom, as we're doing today, and similar platforms, while observing social distancing and lockdowns. Another unintended benefit is the fact that mobile health or mobile medicine also has received greater visibility and respectability. And finally, ladies and gentlemen, in a new film on global health equity, which I came across on Davis, the film is titled How to Survive a Pandemic, and it's going to be aired soon in May. Adrian Houghton writes in The Guardian, and I quote, "If the film's first half is a shocking success story, multiple vaccines with efficacy rates over 90%, its final section is a tragedy. The deeply inequitable distribution of vaccines in which rich, powerful nations maintain a surplus, while low-income nations struggle to reach double-digit vaccination rates and protect the most vulnerable," unquote. Again, Paul Edward Farmer, medical anthropologist and passionate advocate for global health equity, would have been appalled. May he rest in peace. Ladies and gentlemen, I would like to pause at this juncture so that we have enough time for conversation. Thank you very much.
Thank you very, very much, Joseph. And please, you can already leave your camera on as we're heading into the discussion soon. It was very, very interesting, at least for me, to hear your very close insights into like the lived experience of people in Nigeria with neglected tropical diseases, and also the frontline healthcare workers. And one very interesting thing that you said, and important to hear, is that for a lot of people, problems like hunger and inequality were a much bigger threat than the perceived risk of an infection with COVID-19. I think, that very much spoke to me. And yeah, with that, I would like to open the discussion. Dr. Priya, you can also join us with your camera now. And we have about half an hour. Questions from the audience are very, very welcome in the chat. And to get us started, I would just like to say that I'm very much looking forward also to your personal opinions, maybe any suggestions you might have for us on potential starting points for political counteractions nationally in your countries in terms of the global health system, but also, of course, where you see the role of the German government. And to start the discussion, I would like to ask both of you, how do these national issues that you described, in your opinion, link to global health, as maybe a first question to get us started? Whoever would like to start, maybe you, Priya?
Thank you, Melissa, and yes, respected chairperson. From a global health perspective, we know that I think the German government is one of the biggest, I think the third largest donor, for global health, and so many initiatives that the German government is contributing to. And India is a very big recipient of that generosity, especially in the area of health system strengthening. Where I see the need is, I have noticed that for example, on Saturday, just on this weekend, we had a meeting with the Ministry of Health and Family Welfare, the Immunization Action Group, where we had the DAHW representative talking about the various, the HSS2 report and the outcomes and the fund utilization, and looking forward to the HSS3. Now, I found it, yes, there was so many areas over much before the pandemic in our routine immunization, where the Gavi helped a great deal for the government, right from training of the frontline workers, right up to the storage of the vaccines, the cold chain, and then the surveillance, monitoring, you name it, the whole spectrum for all our immunizations under the what we call the universal immunization program were looked after. And I realized what a significant contribution was made in this area. Now, why it's important for us is, how do we as a country continue to sustain that movement which is being done through UNICEF, UNDP, and WHO. Now, these are the development partners we work with. Even as CMAI and many of our mission hospitals, we work with the UNICEF at the various levels. This is important for us because without their support, whether it is procuring the vaccines, or whether it is training of all, just bringing together the frontline workers for training, it is a challenge. So how can if that kind of withdraws, that whole system support withdraws, it will be additional burden in especially in the financial area for us as small hospitals engaged in everyday work. And it's not easy to take on, community health or public health when all your finances are just going towards supporting an acute healthcare system. So yes, the global health contributions from the various countries is important. Our country, we have, from the G20, you have the civil society branch, which is called the C20, and in that, I just attended a recent meeting, and one of the pushes we want to do is to increase our, right now our domestic funding in health from 1.2% to at least 2.4%. That is one of the pushes we want to do. And if that happens, I'm sure we'll be far more comfortable in addressing so many things. And I'm really hoping with India's presidency for the G20, we will have some very strong governance, finance protocols in place. So I hope I've answered a little bit of that question. Thank you, Melissa.
Thank you very much. Yes, definitely. Joseph, would you also like to give your opinion on this question?
Thank you, Corina. Yes. Yes, I do share Priya's view. And straight to your question, I think if anything, if there was any doubt before, the COVID-19 pandemic has made it completely evident now that the world is one integrated whole. You can imagine one small bug starting somewhere in Wuhan. Well, the controversy is still out there, but from all indications, it all started. I never knew this name before, Wuhan, but here we are. And 2 years later, the whole world is sea shedding. In a globalized and increasingly interconnected world, there is no question that what happens in Nigeria or what happens in India must be of interest to the people sitting in the Bundestag. We have to give credit here to the German government, as Priya mentioned earlier, from what we can read, that the third largest official development assistance donor after the United States and UK. And the government of Madam Angela Merkel worked really very hard also within the forum of G20 while the government was still in power. So it's estimated that Africa's population would increase from 1.2 billion now to more than double, 2.5 in 2050. And for Europe and the G20 generally, these are security issues. There's no denying that any longer. So essentially what I'm saying is that what happens in Africa in terms of health, social services are of critical importance to Europe and the rest of the world. And I'm sure that the parliamentarians, the honorable members of the Bundestag will raise these issues in the Bundestag when they now discuss social policy, and the BMZ will try to see what they can do to make sure that the Angela Merkel's effort on, I think they started something actually about, what's the word again? A Marshall Plan for Africa, some sort of an impact with Africa. I think that discussion is going on, trying to improve the investment climate in Africa so that the private sector can move in, so that we don't rely exclusively on ODA, but get the private sector to also come in, so that at the end, there'll be good governance, so that Africa's, the resources in Africa can also be better used for the good of its people and not be simply stuffed away. And I have to add there, in European capitals by corrupt politicians. So if they work together, I'm sure that at the end of the day, we'll all be better off for it. Over.
Thank you very much. I have a few more questions for you, but first I would like to pick up one question, one quite specific question that we got in the chat. And the question is, I will read it out for you, but you should also be able to see it in the chat, and whoever would like to answer can. How well is it that the GPEI, that's the Global Polio Eradication Initiative, polio infrastructure is also being used to address other health crises such as cholera, measles, and most recently COVID-19? Isn't strengthening and promoting such an infrastructure crucial to strengthening global health systems in order to combat further health crises in the global south?
Melissa, may I start?
Sure, and Joseph, you can add in after.
Thank you. Regarding the Global Polio Eradication Initiative, India has had wonderful lessons from that whole program, which finally resulted in eradicating polio in our country. And that is no small task. And yes, Ms. Nathalie, you are right. There are many important learnings that we have got from that program and that initiative and that strategy. And let me talk for our country, for example. Now, for any public health program and success, which even the public health, declaration, I think in 1976, we talk about 4 pillars. When you talk about a structure or an infrastructure, I know it's not a building, but what were the 4 pillars? Health education, intersectoral coordination, appropriate technology, and community participation. These were the 4 things that this polio eradication program built very strongly on. one example of appropriate technology was this whole thing about the SM net, or the social mobilization networking. Now, in our country, there are out of the 36 states and union territories, about 2 or 3 of them, the biggest ones, are the ones who contribute to the lowest indicators of health in our country. So those states were targeted, and we were trying to understand, and this is where UNICEF came in a big way. So UNICEF took on the whole area of mobilizing the community and generating the demand for this polio vaccine, which was being pushed against, because the community, this particular community, did not want to take it. They said it was a bad vaccine and caused infertility. There were so many stigmas and discrimination against the vaccine. So this kind of the SM network, UNICEF, it was started by a small NGO, and then UNICEF has taken it up and upscaled it. Now, that was a good example of using appropriate technology for creating demand, for mobilizing the community, for empowering the community, and also for educating the community. These kind of things, some of the pillars which the polio eradication program in our country built are still being used for all the other routine vaccinations. And they also started being used for the COVID, because COVID also came up with a lot of discrimination and stigmatization against the vaccine. So those learnings definitely helped. And I must say, the 4 pillars of public healthcare or primary healthcare, which the polio strategy worked on, has really served as a fantastic infrastructure for other pandemics and issues where you need a mass or a public health strategy to ensure that people are protected and the disease is not spread. So yes, thank you.
Joseph, would you like to add anything?
Yes, thank you, Corinne. Just to say that there's no question that the days of parallel projects are long gone. To your question, yes, leveraging existing platforms must be the way to go. So you have the polio eradication initiative. There's no reason why such platforms cannot be used to address other problems, including some of the problems I mentioned here now. So integration, if you see the recent WHO roadmaps, be it the NTD roadmap, the one up to 2021 to 2030, or even the recent leprosy WHO strategy, they're all emphasizing integration. There is no room now for such inefficient pursuits with parallel projects. So I suppose, I hope it answers your question to whether one could use this existing platform, the Global Polio Eradication Initiative, to pursue some of these other problems. My answer is yes, and that, I think, is also in line with other approaches like One Health. All these are emphasize the notion that you cannot achieve optimal human health without consideration of animal health and environmental health. And actually, I'm also a proponent of that one. So yes, that's a short answer to your question. Thank you.
Thank you very much. And there's one further question in the chat I would like to put to both of you as well, from my colleague Max, who asks, from infectious diseases to non-communicable diseases, what can be done to provide better coverage for low-income patients with NCDs like diabetes or cancer in the situation of a potential future pandemic?
May I go first, Melissa? So the first part, talking about non-communicable diseases, I must say our government is stepping up, and the way they are stepping up is to address lifestyle diseases. They're calling it more about a wellness approach to health. Now, what does that mean? They are setting up health and wellness centers across all the districts of our country. And there are 600 odd districts. Who will be manning these districts? It will be nurses as well as alternate medicine doctors, as well as MBBS or undergraduate who have just finished undergraduation. So these are the personnel who will be looking after these health and wellness centers. Yes, infectious diseases has its own management, and I respect what Dr. Joseph said in terms of the whole vertical programs is not efficient anymore. There has to be a integration and as well as an intersectoral coordination with like the WASH program as well as the curative part. But looking at the health and wellness, they have about 13 objectives that they're supposed to do. And in that, it is addressing diseases like diabetes, hypertension, and of course, the whole area of cancer, which they are putting under this, the palliative care umbrella also, where the government is taking a lot of initiative to ensure that home-based care is also available. They're doing it through different ways, through training of, maybe school dropouts, or diploma nurses, or those who because our country is big enough to employ a lot of people, but yes, there is a lot of youth who are unemployed, and to give them job opportunities in the health sector, this was one of the areas, this whole home health or home-based or community-based care. Now, what about palliative care? During the lockdown, the availability of morphine became an issue. That was one of the demand supply areas which got affected very much. But this is where the community again stepped up, where they started sharing their medication. And yes, all the documentation of the morphine became a nightmare. But whatever said and done, it is somewhere there is a coordination that happens. And that coordination happens when, like for example, in our communities, about 60% of our 275 mission hospitals, they have an ongoing, robust outreach program, not just mobile clinics going up and down, but an outreach program in the community. Now those programs are the ones which had the trust of the community and which were able to address the issues for chronic care for diabetes, hypertension, and for cancer. Because many of the government centers were not able to give the chemotherapy, the radiotherapy was affected. So in many times, our vehicles from the hospitals started plying the patients up and down. So the government is stepping up, I must say, as well as our mission hospitals stepping up into different roles and ensuring that they go out to the community more than wait for the community to come to them. And this is mainly in the area of lifestyle diseases. So I'm hoping that this movement and this initiative by the government will really take on, and it's already started. And our mission hospital, the main one, for college, the Christian Medical College in Vellore, they're the ones who are doing all the training for these personnel who are going to look after these health and well-being centers. So a lot of involvement from the Christian, Protestant, and the Catholic sector, and we really look forward to these kind of initiatives for these kind of diseases. Thank you.
Yes, may I chip in?
Yes, of course.
Okay, correct. Thank you. And thanks, Priya. I agree with what you said there. I just want to say yes to what Max just asked. You see in Nigeria and a lot of sub-Saharan Africa, we are undergoing two transitions. An epidemiological transition, like the one you referred to now. We used to be burdened largely by communicable diseases. And that was our emphasis. But it is also clear to us now that these lifestyle diseases that are just more and more prevalent here. So we have epidemiological transition as well as a demographic transition. So as you know, we have a demographic pyramid with so many young people down there, but increasingly people are also life expectancy is also increasing here. So we have these transitions to manage. So it's not uncommon in Nigeria and a lot of sub-Saharan Africa. So we have to deal with communicable diseases and at the same time non-communicable diseases, almost a double jeopardy. But we're helped by the WHO and other organizations that actually shining a spotlight on. The WHO, for instance, has a collaborative framework on tuberculosis and diabetes. And we in GLRA, Nigerian office here, pride ourselves on actually promoting that in the Nigerian program. We have a project that actually bidirectionally showed the prevalence of TB among people with diabetes and the other way around, the prevalence of diabetes among persons with TB. And we've been able to get this into policy and practice in the Nigerian program. So yes, this is something that is becoming evident now that we can no longer afford the luxury of saying we are interested in communicable disease and not in NCDs, because both of them have become quite significant here, and we have to take them on at the same time. Over.
Thank you both again. I would like to ask one last question from the chat, and then chip in my last question after that to both of you. This question we got is in German. I will quickly translate it roughly into English for you. You can also see it in the chat again. The question is that we often see that the politics of development, cooperation in richer countries like Germany is often very much focused on medicines and vaccines and the availability of those healthcare products, and that the building of easily accessible and resilient healthcare systems is often being neglected in our investment. And what can we do in Germany to make clear that the availability of vaccines and medicines is not enough to meet the health needs of people in the global south, and that it needs stable and trustworthy structures that are not being led maybe by economic interests. I'm not sure if that question makes sense to you. Otherwise, I will happily reframe it. Joseph, would you like to
yes.
try? Yeah.
Yes, it does. Well, I think I get the sense of what he's talking about. Yes, in fact, I think it comes, first of all, we have to give credit to the German government for trying it, because from what he said, the question is, are those products important? The answer is yes, so we need them. But I suppose what the question is alluding to is that we have to go beyond that. And Priya mentioned earlier, and I think I mentioned in my input, we talked about fragile health systems, which became evident during the pandemic, how fragile these systems are. So to use our phrase, if the infrastructure is not robust, then no matter what you put onto it, it will be difficult to be sustained. So we're talking of universal health coverage. And I keep mentioning the name of Paul Edward Farmer, and he was of the view that if we don't offer quality services to the poor also recognize that we are not offering quality services, and it would affect the trust between them and us. So essentially, to your question, I agree. I think the thing to do is actually it's about also the quantum of investment. So in the BMZ and the Foreign Office in Berlin, we hope that the honorable parliamentarians listening today will make the case that yes, Germany should continue to provide those products, but it should go beyond there to look at the health system so that it will help make it more robust and less fragile. This will mean more investment. And I'm talking of a generational commitment here, not something that will last for the next 4 years of all of issues government, because that's unfortunately, and this is not an accusation, politicians often think really short-termist for the time their government's run, but somebody has to push actually that we need a generational commitment here that would actually put in sizable investment so that the infrastructure can actually be put in place. For instance, let's take one example, the vaccines. You saw the tragedy, the film I referred to earlier. What happened during the COVID vaccines? The science community did a terrific job by collaborating across nations, across board, to produce multiple vaccines. But then what happens? A rat race began, and the nation states simply forgot everything they've been preaching about global solidarity. And everybody was simply struggling for themselves. Governments had to show their citizens that they deserve to be re-elected, but then they forgot the mantra that for as long as there's COVID anywhere on this planet, nobody's safe. So the reason I mention this is it makes sense, therefore, to make sure that the infrastructure for manufacturing such products like these vaccines should be put in place in this in the global south, so that next time around they will not be waiting for handouts from the global north. Over.
Thank you very much. I couldn't agree more with you. Dr. Priya, anything from your side?
Yes, I would just like to thank you, Melissa. I would just like to say that, as CMAI, as the Christian Medical Association of India, we have been the very privileged recipients of funds from our partners in Germany, which is Bread for the World. They have known us for more than 19 years. And I do understand that apart from the Protestant German church, that there is an involvement of funds coming in from the German government. So yes, we are very accountable to all those programs that we do. And all our programs are related to health system strengthening. And what do I mean by that? It means that for our 275 mission hospitals, we try to ensure that we bring in the government programs like an accreditation program of their services. So once that is in place, then they are eligible for government insurance. And once the government insurance comes in, whether it's at the state level or the national level, then the whole idea of resilience, slowly builds into the system. Now, why I'm saying this is because during the COVID and the lockdown, the pandemic, all our hospitals, their income dropped to only 20%. And resilience always talks about how did they bounce back? Did they have the systems and the ability to come back after being shot down to just 20% of what income they were getting? Now, how did they bounce back? Many of the staff took salary cuts. Many of them said, no, we will defer our salaries. Then the whole thing about focusing on the need of the community. Now, this is where the church helped as well as individual donors helped. And of course, our partners helped very much in adjusting the budget lines, and allowing a different expenditure to combat the COVID pandemic. And that for us was a huge, huge advantage and a huge blessing because, just the treatment process, drugs and vaccines was kind of taken care of. But it was these infrastructure and equipment costs that kind of, really pushed the hospitals over the edge, including the PPE. It was a very costly affair on a daily basis for all the stuff. Then there was the equipments required. Then the civil, engineering required to put in your oxygen pipes. buying oxygen from the various local vendors. Everything was a huge capital cost. It was just not about drugs and the vaccine. So when you have funders and donors, and I would say partners, who journey with you, knowing the real need, and all of us being accountable and transparent, I think that makes the difference from transitioning from just, the everyday running of an institution to actually building resilience. Because the trust is what the community has in us. And we need to show that trust on a 360-degree level relationship. So I just want to say thank you to the support that we have received also. Thank you.
Thank you, Priya. We're coming to the end of our discussion time, but I have one question that I would like to ask you. Maybe to split this question up, maybe I would ask Priya to answer maybe just in one sentence or two sentences, your opinion on what you think needs to change on national or regional level. And to you, Dr. Joseph, maybe I would put this question, but ask you what is one aspect that you think needs to change on international level in terms of what you were discussing Who would like to start?
Okay. Mine is
always ladies first. Ladies first. Thank you.
Okay, thank you. So, Melissa, for me, it is the national level, isn't it? Yes.
Yes. So you're on Indian level, or if you want to talk about the regional level, but as you gave us the national overview.
The national level, I would think that being agile is important. For we are almost we are like more than 100 years old in many of our institutions. It is time for us to step out of our little silos and change who we are in the way we function, especially in relation to the government and to our donors, to make ourselves more vulnerable and more, out there, out of our little, compound walls, to ensure that we understand exactly what is going on the national level as well as on the international level, and how we as a small hospital in one part of the country contribute actually to the SDG 3. I think the agility part is what is important for us, and that's where CMA would love to bring about changes. Thank you.
Thank you very much. Dr. Joseph, last word goes to you.
Yeah, thank you, Karina. I just want to say that, in fact, I think what you've done is what teachers do is, for didactic convenience, you divide them into two. The question will not be whether it is, if we want any meaningful change, it's not going to be either in national basis, or regional, or international, as you know, and I'm sure you know that. It's going to be across board. So the Nigerian government, for instance, have to step up and do more. It means that the new SPD government must ensure that they use their weight wherever, in every international forum, to make it clear to the people in power in Nigeria that it cannot be business as usual. There's so much resources are available in country, and yet many Nigerians are poor and going hungry. That it is unacceptable in this century, and that they, as members of the same human family, will not accept that. But yes, we're expecting that the German government will join Gordon Brown in his call for a global Marshall Plan to actually see that the whole world is brought into the 21st century. So that when the next epidemic or the next pandemic comes around, we will all be ready. Thank you.
Thank you very much. And with that, I will close our discussion rounds. We're already a few minutes over, and I will switch back to German now to a very short summary from my side, and then hand over to MdB Tina Rudolph for the final remarks. Liebe Zuhörende, ich wechsle jetzt für die letzten Minuten auf Deutsch. Ich finde, dass Dr. Priya und Dr. Joseph wirklich eindrücklich geschildert haben, welche Gesundheitsbedürfnisse, die auch schon vor der Pandemie, aber vor allem im Schatten der Pandemie vernachlässigt wurden, in Indien und Nigeria, dass sie uns das eindrücklich geschildert haben, aber vor allem auch mit welcher Stärke und Innovation vor Ort gearbeitet wird, um die Gesundheitsbedürfnisse der Menschen dort zu erfüllen. Und wie groß das Feld an nationalen Herausforderungen und internationalen Herausforderungen in diesem Bereich ist. Und wie viele der Punkte natürlich mit globaler Gesundheitspolitik und Fragen der Finanzierung und der Verfügbarkeit während der Pandemie und darüber hinaus verknüpft sind. Und vielleicht 2 letzte Worte von mir dazu, was mich besonders interessiert hat an den beiden Vorträgen, dass Dr. Priya die Wichtigkeit der finanziellen Unterstützung betont hat, die unter anderem natürlich auch jetzt schon von der deutschen Bundesregierung kommt. Und dass es hier aber auch wichtig ist, Kosten zum Beispiel für Infrastruktur und für Equipment sowie persönliche Schutzausrüstung gerade in der Pandemie zu berücksichtigen. Und dass Dr. Joseph sagte, dass er hofft, dass die politischen EntscheidungsträgerInnen in Deutschland sich dafür einsetzen, dass es wirklich langfristig gedacht Gesundheitsinfrastruktur braucht und dass da rein investiert werden muss. Und auch, dass er noch einmal betont hat, dass es von größter Wichtigkeit auch für den europäischen Kontinent ist, zu wissen und sich darüber zu informieren und auszutauschen, was auf dem afrikanischen Kontinent passiert. Und auch das Memento-Bündnis sieht ganz klaren Handlungsbedarf, auch von Deutschland und der Bundesregierung in diesen Bereichen. Und hiermit würde ich gerne für die letzten Worte zurück an Tina Rudolph übergeben, die unser diesjähriges Memento-Fachgespräch dann beenden wird. Frau Rudolph.
Ja, ganz herzlichen Dank, Frau Scharwey. Mir bleibt dann auch noch eine ganz kurze Zusammenfassung zu ziehen. Und ich glaube, Ihnen und euch geht es auch ähnlich, dass viel von dem, was wir gehört haben, auch immer noch sehr nachwirkt. Ich bin sehr, sehr dankbar, dass wir 2 so tolle ReferentInnen hier hatten und dass wir all das hören durften, was Sie uns aus Ihrer alltäglichen Arbeit in den letzten Monaten auch berichten konnten. Mir ist ein Satz sehr im Gedächtnis geblieben, den Dr. Joseph Chukwu formuliert hat. Ich übersetze jetzt ein bisschen freier, dass die Pandemie einmal mehr deutlich gezeigt hat oder vielleicht so deutlich gezeigt hat wie nie zuvor, dass die Welt ein großes Ganzes ist, aber auch wie ungleich die Welt ist. Und ich glaube, das haben wir gemerkt und das wurde gerade auch sehr stark nochmal unterstrichen, dass die Ungleichheiten, die wir auf der Welt finden, durch die Pandemie nochmal sehr stark verstärkt wurden. Und dass es schwierig ist, wenn eine Pandemie auf Gesundheitssysteme trifft, die ohnehin schon mit der Akutversorgung vor sehr, sehr große Herausforderungen gestellt wurden. Und mich hat umso mehr beeindruckt, aus den Schilderungen von Dr. Priya John konnte ich das sehr, sehr gut entnehmen, wie viel und wie hart sie gearbeitet haben, um trotzdem eine Gesundheitsversorgung sicherzustellen. Und wie bewundernswert es ist, dass trotzdem das Alltagsgeschäft, auch das Outgoing, also die ambulante Patientenbetreuung weiter aufrechtgehalten wurde, dass weiterhin auch Datenerhebungen stattgefunden haben, dass Medikationen trotzdem so gut es ging weiter aufrechterhalten wurden für Krankheiten, für die das einfach notwendig ist. Das ist etwas, was wir einfach sehr bewundern können und wofür es einfach gilt, den tiefsten Respekt zu zollen, vor welche Herausforderungen diese Gesundheitssysteme gestellt wurden und auch immer noch gestellt werden, weil das, was die Pandemie dort verursacht hat, natürlich auch noch längst nicht aufgearbeitet ist. Ich nehme auch den Punkt der Resilienz nochmal sehr dankbar auf, also auch die Frage meiner Kollegin Katrin Vogler hat es ja auch nochmal gezeigt, dass Resilienz weitergedacht werden muss, also die Resilienz von Gesundheitssystemen als auf die Versorgung mit bestimmten Arzneimitteln oder jetzt primär mit Impfstoffen, obwohl das natürlich auch ein wichtiges Thema ist und auch globale Impfstoffgerechtigkeit ja noch nicht so verwirklicht ist, wie wir uns das A als internationale Gemeinschaft mal vorgenommen haben und wie das B eben auch einfach nötig ist. Und trotzdem würde ich nochmal fokussieren wollen und daran auch dankbar anknüpfen, dass die Stärkung der Resilienz von Gesundheitssystemen eben auch ein großes Thema der G7-Präsidentschaft in diesem Jahr sein wird und dass Resilienz eben auch zusammengedacht werden muss mit dem Gedanken der internationalen Solidarität. Auch hier sehr schön fand ich die Schilderung von Dr. Priya, wie sie vorgegangen sind, dass die regionalen Kliniken in einem Brief an den Premierminister verdeutlicht haben, die Frage, die wir uns stellen, ist, was ist nötig? Wenn es nötig ist, dass eine bestimmte Versorgung aufrechterhalten werden muss, wenn es nötig ist, dass ein Krankenhaus eben als Primärklinik funktioniert, dann machen wir das. Und ich würde mir wünschen und hoffe, dass wir das auch hier in die parlamentarische Arbeit tragen können, dass Resilienz dann entsteht und eine wirkliche Preparedness vor einer erneuten Pandemiesituation, wenn wir alle uns genau diese Frage stellen: Was ist nötig? Nicht in einzelnen Fonds zu denken, nicht in einzelnen Budgets, sondern das große Ganze sehen. Und wir haben uns auf die SDGs zum Beispiel geeinigt. Im SDG 3 gibt es da auch konkrete Zielvorgaben, die wir erhoffen zu erreichen. Und ich hoffe, dass wir es schaffen, in den kommenden Jahren und Jahrzehnten vom Ende her zu denken. Das, was getan werden muss, muss getan werden. Und dafür braucht es die internationale Solidarität, und Deutschland soll und wird natürlich da auch seinen Teil leisten. Umso mehr, das möchte ich aber auch nochmal betonen, freut es mich, dass auch das Engagement Deutschlands international so positiv gesehen wird. Es ist in den letzten Jahren, glaube ich, auch einiges passiert, was diese Sichtweise auch sehr verdient. Und es gilt aber für uns auch eben daran anzuknüpfen und das genauso aufrechtzuerhalten. Sowohl wenn es um die Finanzierung einzelner Instrumente geht, als auch wenn es um das große Ganze geht, nämlich Compassion und Kohärenz für dem, worauf wir uns verpflichtet haben, zum Beispiel was die SDGs angeht. Damit komme ich wirklich zum Schluss und möchte mich nochmal ganz herzlich bedanken bei unseren ReferentInnen, aber auch für die wunderbare Moderation und bei Ihnen und euch, die ihr heute an diesem Morgen euch in diese Veranstaltung mit eingewählt habt, und wünsche uns allen, dass die Erkenntnisse und das, was wir gehört haben, noch gut nachhallen wird. Und ansonsten viel Erfolg für die weitere Woche. Danke.